Welcome to the CMC Vellore Cardiology Alumni Meet, where memories are revisited, stories are shared, and bonds are strengthened. Today, we celebrate not just our accomplishments, but the journeys that shaped us, the long nights, the shared laughter, and the unwavering spirit that defines the CMC family. CMC is not just a place, it's a feeling. It's the late night rounds, the hurried lunches, and the unmatched sense of purpose we found in these walls. It's incredible to see how far this community has come, from first year residents with dreams in their eyes to cardiology leaders shaping the field globally. Every alumnus here carries a piece of CMC's legacy. Together, we represent a story of perseverance, innovation, and compassion. What makes CMC unique is not just the medical excellence, but the ethos it instills in us. The belief that medicine is much more than science, it's service, it's humanity, it's art. And that belief stays with us wherever we are, here in the world or halfway across the world. Of course, no reunion is complete without a bit of history. We've all heard the stories, pranks, the nicknames, and those infamous post-call escapades. And judging by the laughter echoing across the room, some things never change. Here's to the journey that brought us together, to the friendships that keep us connected, and to the memories we can take forward. This is not just a reunion, it's a celebration of what it means to be part of the CMC family. Cheers to the past, the present, and the future. We continue to shape it together. We cheers to the silver equity. The Cardiology Alumni Reunion is happening and we're all excited. I'm really thrilled to have Dr. Lijo with us. Dr. Lijo is right now in Coimbatore, but he was like part and parcel of us when he was here. And Dr. Lijo, we'd like you to talk to us about your time in Vellore and the things which you remember.
So I had a very good time in Vellore. So I was here till 2020. I finished DM in 2012, and 8 years I was here. So it's an unforgettable time. So one thing is, you don't realize the worth and value of CMC when you work here. When you go out, you realize how of a protected environment you are. More importantly, the experience that you get in CMC, that is unparalleled. I mean, the teachings, the learnings that you get from here stays with you forever. And more importantly, in a private practice, the ethical part of it remains with you forever. So that's something which would really cherish throughout my life. Thank you.
Dr. Lijo, there are a lot of things which we've heard about you. Some of the things were that you remember the stints, the sizes of patients who you've done, and the other thing is how fast you were. So, can you tell us a little bit about your cath lab time?
Yeah, so probably that probably follows Dr. George sir. I mean, he'll probably also remember the stent sizes and names right from, you can identify the angio and then relate to the patient face. Whereas you ask for a relative's name, I will not remember. So that's something that happens. You just have some kind of, I can't say the knack there's no technique for it, but it just happens that certain things you remember better. Something done 2 years back, offhand, not all patients, some random patient, maybe something interesting related to the case you may remember, or some complication has happened, you've done a bifurcation or something like that you may remember. So, and speed of the procedure is something which I always keep, even now I still do the same. So that is something, keep it short and simple, don't complicate it, that's the main thing.
That's right, sir. And can you tell us a little bit of your time in residency? Do you remember things in residency?
Yeah, so residency was 2009 to 2012. That time was three of us, myself, Vipin and Devi. So Devi was the pediatric person who came on to do adult cardiology. And we had a good time as three of us in the PG gang. It was quite hectic. I mean, 3 PGs, you can imagine the workload was really high. I mean, 9 of us in the department that time. And for Devi also, she had a lot of issues because she came to adult cardiology from a pediatric background. And, the dosages, tablets, everything was very difficult for her. But we managed. And I can't remember any stories offhand, but it was a very interesting time that we had. I mean, something we shall never forget.
So one last question, sir. To us as residents, or probably somebody who is going to join for the first time, Is there anything which you'd like to tell them?
Yeah. So I think hard. Learn from your seniors. Observe what they're doing. The meticulous planning, for example, like let's say John or George has for a case, and perseverance and backup plan. So keep observing, watching, and more importantly, if you are going outside world, ethical practice. Remember what CMC stands for and the things which have imbibed in you.
Thank you, Richard. It was lovely talking to you. Thank you. Thank you so much. So we are in the Cardiology Alumni Reunion 2024. I've got with me Dr. Anup and Dr. Sirish, who are probably one of the most accomplished cardiologists in CMC. So it's great to have them, and let's ask some embarrassing questions to them and try to relive their moments. Dr. Anup, let's start with you. So, can you think about your cardiology residency days, and can you tell us something which you remember?
Yeah, so residency days, as we all know, was tough. But what shone through during that time was the friendship that we created, especially Sirish, who is my colleague even now, and Anand, who is in Australia now. I thought we three were a close group, along with Pranay, Geetesh, and Kunal. So the friendship that we created, the bonds that we had with our mentors, shone through better than the degree that I got.
Thank you, Dr. Anup. That was good. What about you, Dr. Sirish? Is there anything you remember fondly from your residency days?
Yeah, the most striking moment probably is 1 year into my residence. 1 week into my residency, I just ran off without telling anybody.
Okay, there's a surprise.
Now here I am 2 years later, still continuing here. Yeah, so things change. Our perspective changes. So
Can I ask you who convinced you to come back?
it was partly like my family sent me back saying that you try once more. But I think Anup, Paul sir, OG sir, Pati sir, mostly these were people who had a chat with me and then sort of convinced me saying that you'll go get through it. So I stayed back.
That's great. I don't know about this. Definitely, yes, yes.
Don't have minds like this. Celebrate those minds and foster those minds, and I think we have a fertile ground for such minds to grow.
So, can you tell us, Dr. Anup, Dr. Sirish, who are your teachers, people who you fondly remember?
Yeah, so we had Paul sir, OG sir, Sunil sir, Vijay sir, George Joseph sir, and Jacob Joseph during our times. I was more than cardiology, especially, is a stream where you learn the maximum once you pass out, and I will be always be greatly indebted to Manjot sir, who was my mentor, and in many ways. So whatever I am learned, procedure wise, patient management wise, thinking wise, I kind of put it in his feet, and I think everything. Most of I know credit to all the others who have contributed, but I learned the maximum from Manjot sir, I would say, as a interventional cardiologist.
That's a wonderful tribute, sir. Thank you for that. Dr. Suresh?
Yeah, so I mean, you learn something from everybody. It need not be didactic or formal teaching, but you pick up those nuances, like how they approach a particular problem, even clinical otherwise as well, administrative or dealing with a difficult patient. All these things you learn like sort of bits and pieces from individual teacher. So I cannot sort of pick one out and say that he was the most I learned from, but I would say I learned from everybody. But as like a human being, like how to approach people and this thing, I learned a lot from Dr. John Roshan and yeah, of course, the systematic way in which he approaches a case, I learned from GJ sir, and how to deal with lots of patients or just heavy case list, but still smile from OG sir. Things like this, I cannot like individually pick up, but like things like this, these are the things which I learned from everybody. So,
I would add, sorry, but I would add John Roshan's name to it, because he was also my mentor in many ways, and I learned what teamwork is, and I learned that medicine is also teamwork. When we say teamwork, we say in the realm of sports, in the realm of maybe corporate world, but I understood that medicine, especially in a medical college like this, where we are working in units, is more of a teamwork. and they've realized how the leader should be the servant from John Roshan sir, the essence of teamwork and how we should foster the team as well. You see, EP, as I would say, is one of the best in the country. All credit to him, I would say, to foster the team.
Thank you. Thank you. There's one last question. Just remember your time as a first year. So, can you tell us from the time you get up till the time probably you sleep, what all you would do and what time would probably the day start?
Yeah, I mean, we used to, with our, in some units it was very difficult. So, right from the time we wake up, it was run after patients, sort out things, admit, write case sheets, discharge them, COP, go back at 11 o'clock. So, it sort of became so much of a routine. I don't remember any striking. It just was how the life was back then. So, I don't remember any striking moment. It was just like that.
Yeah, it was pretty hectic, as Sirish was mentioning. Um, it was Monday to Saturday OPDs, and the OPD starts at 8. So we had to come, take care of our patients, do everything that is required, have a quick rounds and reads by 8, 8:15. By 8, 8:05, 8:10, the calls used to start. Why are you not there? So, and then go through the busy OPD till around 4:35 or 5:36 sometimes. Then arrange beds. That was the most difficult part that we had.
In fact, almost majority of our work was we were thinking about how to get the bed for this patient.
I remember the academics was evening during those days, and as first years, our main concentration during academics was the give and take of the beds rather than what was happening in front, and then admit and do everything for the next. So it was long days. We used to get up by around 5:36 and sleep by around 12:31 for 1 year. So yeah, tough days, but the growth happens through struggle.
Agree with you, sir. So, thank you so much. We had a fun time talking to you, remembering old days. I'm sure you'll have a great day. Thank you. Thank you so much. So, we are in the middle of our Cardiology Alumni Meet in 2024. I'm privileged to have Dr. Sunil Sandy with me, who was the head of our department of cardiology and also a director in Christian Medical College, Vellore. Thank you, sir, for this interview. And sir, I'm sure you would have had a really an interesting time here. And could you tell us your time when you were a student from MBBS days, MD days, and DM days? Could you please tell us?
Thank you, Abhi. It is such a checkered journey because when you get into medicine, it is like getting into a forest where the pathways are not clear. But as you go through, especially in CMC, you will find that a lot of things will become clear to you as you go through that journey. So for me, going through MBBS was, of course, a privilege to be in one of India's best colleges. But more than the academics, or just as important as academics was, it was also to see a way of life that was truly inspirational. I remember seeing our professors at that time who are not there anymore. Many have retired, many have passed on. But their lifestyle, their very austere dress, and the friendship that they extended to students, the foster system, which allowed me as a medical student, us as medical students, to go visit their home and take part in so many activities. So it was about a way of life that CMC offered. And at the age of 17, 18, 19, those were the formative years which everything was put into a package where you learn top notch medicine from excellent teachers who also have another life when they go back home. They are friendly and they teach you values and they teach you a way of life that somehow remains with you throughout your life. Going for retreats, singing songs with them, going for their family events where you become part of their foster family, always concerned when you fall ill, and their general way of life, their simplicity. Those days, many did not have cars and they used to travel by bus. All these things are small things, but had an impact on my life, on what it takes to be a caring physician. It was not just prescribing or doing surgeries, but the whole approach of how do you treat a human being. In postgraduate, again, it was a higher level of academics, but the same philosophy of spending lots of time at the bedside, asking patients, caring for them, teaching you to be compassionate, teaching you to inquire about them as a person, the family that surrounds the patient, charity. So these are all things that were packaged with high quality clinical training. So that has carried on, and it kind of gets into your system. So in whichever position you are, whether you're in the missions or back in CMC or in a private hospital, that becomes your DNA of practice. So even in private hospitals, you practice with the same kind of ethos, the same kind of compassionate care paradigm that you were taught. So those are my learnings from CMC.
Thank you so much, sir. Uh, just because you mentioned, I remember coming to your house for one of the carol rounds. We had amazing food. So, of course, like how you said, the way we look up to you. For instance, you are my group observer, and so we look up to you. But then, do you think what are the ways in which residents now that things are moving away from clinical medicine? How do we stick on to clinical medicine and keep the patient in the forefront?
So, globally, worldwide, there is a moving away because technology has developed so much that today diagnosis is possible with machines, with automation, with digital technology. That's the good side of how medicine has advanced, and it actually helps you to be more accurate, more precise. But it should not be at the cost of what is essential to patient care, which is to treat that patient as a person. That when he comes to you with chest pain or a fever, to go into the history, to know his background, okay? And only when you listen to the story and the surrounding from which a poor patient comes will your sense of empathy get stimulated. Otherwise, machines, and we are looking into a future where increasingly machines will do the job of a doctor. Your record keeping can now be digitized. There'll be AI systems that will capture the conversation and put it into text. They can take a point of care, one drop of blood, and do 1,000 tests. Machines will do lots of things. Surgeons will be replaced by robots. That's the direction in which it's going. Yet, I believe that time has not yet come for the physician to be replaced. Okay, so that I think is very essential in staying very central to your physician's core. Okay, when I say physician, it doesn't mean physician as an MD, but surgeons are also physicians, obstetricians are also physicians. So that's the essential thing that you must teach the medical students. There has to be an extra effort by teachers to take them to the bedside. Community health program is something that was an eye opener because they threw you into the village to get your hands soiled, to talk to villagers. So you saw a different kind of life. Likewise, in the reality of technology advancing, becoming automated, dehumanized, less dependent on humans, there should be an extra effort to take young medical students in their formative years to the bedside, ask them to talk to the patient, take them to where they are. Only then will the core of being a physician will stay alive.
So one of the things which the Cath Lab staff remember fondly are your Christmas Day programs. A lot of fun. So can you tell a little bit about that?
So, again, just latching on to what we just discussed, I have learned, and I'm a strong believer of if you want to keep your workmates in cohesion, I have learned that it's actually what you do outside the realm of work that helps you to create that bonding. Because work is high strung, it's very stressful. It's possible that I, as a senior, may reprimand you, you will get offended. But where do you break that barrier down? It's only when you come out and say, let's go for a cup of coffee. And once or twice or three times a year, it's very important to use a festival like Christmas or somebody's birthday or somebody's wedding just as an occasion to create fun and frolic, because there is great power in that. So it helps you to become friendly, which then helps you to have less tensions at work. So the platform of workplace relationships is not created at the workplace, it's created outside the workplace. So we must go for coffee breaks. In between rounds, you must go for coffee and not talk about what you've done at work. Talk about something else. Talk about the latest movie, or new shirt that you may have bought, or something that happened in your home. Laugh a bit, go for an outing, take your workmates for a picnic or a retreat. That's very important. And that's the reason why, not just in the cath lab, but even in the OPDs, on the eve of Christmas Eve, we would just stop work for 5 minutes. Nothing will happen if you stop work for 5-10 minutes. Just come out and say, today is Christmas, we are serving you cup coffee and cake for the patients. You can see the change that they have. Suddenly they are less complaining. They know that something different has been done. So I'm a great believer of 3 Fs: fun, frolic, friendship, fellowship. 4. If you do this, then you will find that your work itself is a pleasure.
One of the things which was part of your vision was this campus, isn't it, sir? Like, I remember you saying that your vision was in this beautiful campus where the poor and the rich would walk hand in hand to receive the same kind of treatment. So, how does it feel to be in this place?
Well, it's very humbling. First of all, it is not my vision entirely. I was only instrumental in doing the relay race of a vision that a former director, Dr. George Chandy, had. The land was bought, and then the need was so great. We were already seeing terrible space constraints, which was decreasing the quality of patient care in the main hospital. So that has overlived its limits. So there was a need to do that. Now, from the CMC's perspective, we wanted to create a state of the art facility, but in such a way that it will not deny the privilege of being treated even in this high class facility. So we created the both and model, and the team, the council, the administrators, everybody joined together to make it a collective vision. Not an easy task, but it was possible. And today I'm glad to see that in the foyer outside, it's not the rich people who are sitting. Most of them are the same patients who are there in the main hospital. And I'm told, I'm not sure whether the numbers are correct, still about 60 to 65% of patients who are accessing this new facility are not the ones who are super class, but they are from the middle class and the lower middle class. So I'm very happy that it's done that job, and we've not deviated from our commitment to the ones who don't have enough, and that this state of the art facility is open to all. So it's very heartening to see that it has been a successful, and I praise God, thank God for that.
One last question, sir. Let's say you were to join as a DM cardiology resident. What were the things you would do? It's probably for a first year resident to take back home.
If I join as a DM student, okay. Well, I think it's a summary of everything that we have just said. That first of all, to know that it's a privilege to be a part of this great heritage of CMC, to get into a DM seat in the Department of Cardiology is a unique privilege that people fight for, and so it begins over there. The second is to utilize every moment of that 3-year training, not just patient care, but also to look at your mentors and see how they operate, how they do procedures, how they communicate with patients, and also become part of the community, because a lot of your life learning comes from things outside your department, the functions in the college, the functions in the colony that you live in, your interaction with your co-registrars and your seniors and your juniors. So it's about that camaraderie, that 3 years. Now I think you have 6 candidates per year. So you have 18 candidates, all from different strangers who have come together for 3 years. So make that a small group in itself, where you compare notes and you become a peer group, where you become the group that takes this flame from CMC to whichever place that you will be eventually. So I think it's a great time which will never come again. Hard time, a lot of hard work, but that's what will give you the foundation of your life and your career in the future.
Thank you so much, Dr. Sunil. It was a pleasure talking to you. Thank you.
Best.
Thank you so much. Thank you. Today, I'm privileged to be with Dr. Thomas Alexander. So, he's a very accomplished cardiology alumnus from Christian Medical College. He's currently in Coimbatore. Sir, it's lovely to meet you, be with you, and so can you tell us some of the things which you fondly remember from the time in CMC Vellore?
Well, I had the privilege of being here from 1974. I did my undergraduate training here. Except for 2 years in between when I went to do my bond after my MBBS, and then came back in '83, did my MD, stayed on, did my DM, and then worked as a lecturer. I finally left in '91. So it's been almost an uninterrupted period of 74 to 91. And I've seen virtually the transformation of cardiology, the practice of cardiology, from being just pure clinical specialty, where you spend a lot of time by the bedside looking for signs, symptoms to make the diagnosis, because the only tools you had those days was an ECG and X-ray. And some of these patients you were taken to the cath lab. But again, remember, cath lab, you had cath procedures, but again, limited by the technology even at that time. And to think that you could diagnose complex congenital heart disease or severity of valve disease enough for you to send these patients to surgery. Remember, that was the modality of treatment those days. With these limited tools that were there available, essentially it meant that your clinical skills had to be so good. And I was fortunate to, live through that period when your clinical skills had to be so good. And then to the time when technology assists you. So I think I've got the best of both worlds. And today, when I look at some of these hospitals where the PA or the physician assistant does the initial examination, sends all the investigation, and then the consultant comes and sees them only after the investigations are done. I think how different things were, and also that personal touch where you spend time looking for signs, and that's really interacting with the patient. That has disappeared from clinical medicine, and that's very unfortunate. And I think people of my generation who lived through both these periods got the best of both. So I think that's, to me, unfortunate lost part of clinical medicine, and I wish that the younger generation gets that back, because it's so important for a patient to have a doctor stand by and talk to him, ask him questions, feel him, touch him. I think that is something that medicine is losing, and I think this is something I value so much. And I look back and I think the teachers who taught me that part of it. Maybe the other part of it I learned at the end of my training period and subsequent to that. But I think both have to be combined in order to make a good doctor. And I think cardiology is just an extension of clinical medicine, and I think you need to have, whether you're doing a very technology heavy specialty like cardiology, which is now what it is. I still think you can't miss out on the other part.
Thank you so much, sir. That was very. I'm not able to grasp how, without an echo, you actually were able to send a patient for surgery. Can you tell us, like, a little more in detail what exactly would have done that?
Okay, so this is even before my time, but I've heard them talk about taking a phonocardiogram to clinical rounds to measure the A to OS interval in a patient with mitral stenosis to decide whether this is a severe mitral stenosis or to confirm based on your clinical picture before you send this patient, say, for a CMV or for a mitral valve replacement. We would take patients those days based on your clinical examination and findings. Say for somebody with mitral stenosis, we take them to the cath lab purely to image them to see what is the calcium that is there, and we would make a diagnosis of a heavy calcium. Now this patient needs to go for a mitral valve replacement, or there's only mild calcium. The first sound is loud. The opening snap sounds sharp. I think this should do well with a closed mitral valvotomy. So I think these subtle signs that today we may not emphasize, because you have echoes and you can do everything. You can make out how your valve is mobile. You can see the calcium and all these things. Those days we had no such tools, so you had to depend on your clinical skills. And there were these very astute clinicians, and I'm talking about Dr. IP Sigma, who I think was the most brilliant clinician. And imagine those days, complex congenital heart disease, you know. And I'll give you another example. If you were to look at, say, the first echo machine that we had was a pure N mode echo machine. Can you imagine that? We didn't have 2D. And if you had in the ward, say, we had a patient with, say, a cyanotic heart disease, and clinically it looked like it could be a tetralogy sort of a patient. And obviously the differentials are a DORB, VSGPS. And if you're going to send this patient, you need to be sure what is this. Now, with an M mode, I don't know if anybody would ever do to look for mitral aortic continuity. Okay, can you do an M mode of a mitral aortic continuity and tell me that? Okay, so just with an M mode, you would look for mitral aortic continuity to say that okay, this is a tetralogy, this is not a DORB. Okay, your clinical, there were these clinical findings where you see is the aorta anterior, are you feeling the pulsations? These were clinical skills that were amazing. And then at cath, it was usually a right heart cath. Okay, it was the saphenous vein cut down that was done. It was unusual to do a left heart cath. So you'd wait for the levo phase and then see what was the left heart looking like. So this is the sort of, but the clinical skills had to be so good for you to then say that, okay, to the surgeon, that here's a tetralogy for you to correct. So I mean, it's for you. This must be something. I mean, you can't believe that can be done, but that was the way clinical medicine was practiced, or cardiology was practiced those days.
It's mind-boggling. So, if I may ask you one last thing, so to maybe a first-year resident who just joined Christian Medical College Cardiology Department, what would you tell him, and how should he work in residency to be a better cardiologist?
Well, I think I often, when I go for rounds with my residents, I try to tell them the bits of history of cardiology, because to me, you need to be inspired in order to love the subject so much that you want to do well. Okay, so if you're just doing it because you think it's a good specialty, I can make a lot of money with it, with a lot of procedures I enjoy, yeah, you will be an average cardiologist. But if you think this is the most amazing branch, if I look at the history of how this developed, of the surgeons who did the initial surgeries and what they did, this is why I think you need to get a feel of what cardiology really is and where it's come from, what it's evolved to. And if you are inspired by that, irrespective of everything else, you'll be a good cardiologist. And then, of course, I think it's important to realize that the whole world practice of medicine has changed. You know, the commercialization of medicine is sort of in your face everywhere. You walk out, you see advertisements all over from private centers that claim to do uh, impossible things. You are flooded with offers from corporate hospitals, and where is are the private centers where you get paid much more than what you would do in an environment where you practice ethical medicine. So I think these distractions are the reality of what practice of medicine has become over these last years. And I think for somebody who's coming into the specialty, I think it's important not to be distracted by that. First, secondly, I think it's important today, and again, I keep emphasizing this. Um, Everything that you read in a journal, even in a reputed journal like even NEJ, be be a skeptical cardiologist. Balance everything. Look at what your practice shows you. See what the data is. Does it really fit in with what you think about? And because many of these are, as you look into the details, are commercially driven, are funded trials, funded procedures, which may not have the benefit that it claims to be there. So when you read journals and you look at hard data, scientific data, be be very careful in analyzing it for yourself and looking at it and then seeing, is that, can I translate that into my practice? And if I were to translate it, what would it cost my patient? And what if it's going to cost my patient? Is the benefit commensurate with the cost that it entails? And I think today this is something that I didn't really need to do it at my time, because I think publications and studies were a lot closer to what we need to practice. Today, that's not true. I think commercial interests have flooded. You look at even if you have five authors, you look at four of them, they would be funded uh, for their research, for their work by the same companies that they're doing research for. So I think it's become more difficult to sift what is real progress from what is commercial progress. And I think for a youngster, I think it's important for them to understand that and to decide for themselves whether a certain new procedure or a new direction is what he needs to move into. And look back, if I look back at the way the department was, we were slow to adopt new procedures, and that cautious approach was a deliberate thing that the department had. We would take, we would read about new procedures, and then the caution was always wait till you see what the fallouts or the disadvantages of that before we adopt it. Today, I think there's so much of commercial and business interest in pushing procedures as soon as they appear, that you feel you need to adopt these very quickly. Otherwise, you're lost in the race. But often you find that some of these procedures fall by the wayside, and you have examples like the BVS fiasco. You take even before that, the directional coronary atherectomy. The data was so sort of shaky, but people had to adopt it because it was like if you didn't do that, you were behind times. Or you take the LA appendage closure device today, the way that it's being pushed. I think if you look at the hard data, the data is really not there. So I think today it's more difficult because of the commercial interest in the way data is being pushed. So for a youngster, I would say don't rush into new procedures, new things without really evaluating for yourself. Is this the right thing to do?
Thank you so much, Dr. Alexander. My love for cardiology has definitely grown after talking to you, and thank you so much. I had a wonderful time. So, good evening. Today we are in the alumni meet of Cardiology CMC Vellore. I'm privileged to have with me Dr. Varsha and Dr. Kumar with me. They are prolific cardiologists and trained from here. Welcome back to CMC. How does it feel to be back?
Thank you for having us, and first of all, really thanks for organizing get together like this. And of course, coming back to CMC is coming back home for us. It's always good to come back to this place and discover new things that have happened here. And yeah, it's obviously a pleasure to be back here.
Thanks for the invitation. It is a real pleasure to be back at home. CMC Vellore has been such a pivotal thing in our lives, the good training that we received here. This reunion is a good thing that has happened. This happened 10 years back exactly when we were registered here, 2014. Again, it is happening. It's really nice. Thank you very much.
That's great to hear. So I'm sure the time in residency is what we would like to hear as residents. So I'm sure it was tough. So, but can you tell us like what would a gentle day in residency would be like during your times?
Yeah, it was tough, but now if you look back, it was fun also. We had a very good bunch of batchmates. 6 of us, we had real good time. Typical day would be like wake up at around 6 o'clock, 6:15, and be in the ward by 7 max. And the rounds gets over, and you rush to the OPDs and eat some snacks in between the OPDs. Then again, the lunch, we would not miss the lunch. We would miss the breakfast, but we would not miss the lunch. Then again, finish off the OPDs and rush back and do your admissions and find bed. Bed finding was one big thing, and find the bed and write all the notes and make the cath lab list. The typical day would end by maybe around 10:30, 11ish when we were in Unit 2. And Unit 1, it would end even a little bit later, but that was how it used to be.
Now, Vijay sir is not listening. Kumar, tell the truth. Yeah, pretty much. It was. It was not fun while we were experiencing it, but now I think looking back, I think I really owe a lot of my success to the rigid training that we've had. Like we were, I think, I feel looking back, it was a lot of overwork. We were overworked, but then I guess right now that's what differentiates us from any other cardiologists in the places we practice. Because I think the training we received, the amount of sheer volume and the quality of clinical work that we had to do. I think that's what really braced us to handle what we have right now.
So, talking about learning, so who are your teachers and what were your fondest memories learning from them?
We are 2013 batch, 13 joining and 16 pass out, 17 pass out. So teachers that time, HOD was Dr. Paul George, this Unit 2 head, and we had little bit of incoming outgoing teachers. Dr. Pati was there in Unit 2 when we started, and when the middle of this thing, Dr. Lijo and Dr. John were our basic teachers in terms of intervention and in the cath labs. Of course, Dr. GJ was always there. We were scared to talk to him or anything, but GJ was always there. But people who handheld and taught were Dr. John Joes, Dr. Lijo. We learned a lot from clinical stuff and this thing from Dr. Paul sir, because the HOD used to a lot of interest in the academics. And Moment sir, unfortunately, was not there when we were initially was there, and he went on a sabbatical. We were not able to work with him as much as we would wanted to. But yeah, Paul sir, Lijo, John, then Pati sir. Pati sir also in between, I think he also went to Australia. So these were our predominant teachers.
Yeah, I think, along the line, we end up finding lot of mentors, I would say, rather than teachers, because In other terms, I think you learn something from everybody. You learn how to do and even how not to do. I think everything is a teaching. Yeah, I think for me, I think I'm pretty thankful for many of the mentors that I found along my journey in CMC. So to name a few, certainly Dr. John Roshan has been a great mentor to me. Even now, he continues to be a great mentor. I regularly keep in touch with him. Same thing, I would also need to mention about Dr. Sujit Chapo, who was really such a great personality to have, and I've really not just the cardiology, it's about how do you time your day, and you need to give importance to your personal life, not just at the profession. So yeah, just to name some that Kumar didn't mention, I think yeah, this is what I would add.
So let's say you are to meet one of our first years. What would you tell them? Looking at his cardiology life and this is starting his career in CMC. What would you tell him?
Why?
Life looks tough now, but these 3 tough years is going to shape your future. So don't get worked out. I mean, enjoy the 3 years. It is compulsory. I mean, you have to go through the drill, but this is going to take you a long way in your professional careers.
Yeah, so there's that saying, no, the harder you get beaten, the better sword you become. So
I just got some few rapid fire questions just out of the blue. So let's start. Okay. So what was your favorite hangout spot in CMC?
for me, Chinatown.
Jewad,
So any nicknames for your fellow registrars or consultants? You remember?
Nothing that we can remember or reveal.
Okay. So what would you do post duty? Just post duty, what would you
sleep.
Yeah, I second that, sleep.
do? What is the longest period of duty you've done?
I had to cover the CPU for 2 days continuous. That is 48 hours I have done once. Second time I have done is 36 hours where we did one long case and night we had to come back to redo the case and morning I had to do the OPD. Then I had to go back at the night. So twice done 48 hours.
Yeah, I think the same thing. The longest I had been kind of on a duty was around 48 hours. And like he mentioned, no, I think the six of us who were batchmates, we were fairly well bonded with each other. We actually had no major. We used to actually cover up for each other so that nobody really had a burnout. So when somebody needed leave, we were actually. So that's what led us to doing a 48-hour shift to cover one another. So yeah, I remember this ICU posting was when we used to like we had to do a 24-hour shift. That was the routine. But then we used to do cover for somebody, so we used to do a 48-hour shift just to cover them.
So in a normal this 48-hour shift or something which is prolonged, how many number of coffees would you take?
Vellore is pretty hard, so I don't think we used to drink that many coffees. But yeah, one or two. We had one coffee, this thing right next to CPU. Avin was there, so we used to frequent there because CPU. That is where we used to do most of the work in the this thing. So yeah, not much, but not much of coffees. Yeah, OPDs we used to. OPDs we used to get up and go every 2 hours once, but in the ward I don't think much.
Yeah, talking about the 48-hour shift, I think towards the end of our first year when you've done quite a few months of ICU rotation, no? I remember one day very vividly, I actually timed myself from the time of nurse calling me for a patient in chest pain unit to the time I came back to the duty room to sleep. For an anterior wall MI, for thrombolysis orders, talking to the relatives, writing case sheet, ordering investigations, everything took me under 5 minutes. That was the time of receiving phone call to coming back to the room to sleep again. So that is how efficient we got by the end of that 1 year.
So interesting, very interesting talking to you. Thank you so much, Dr. Vash and Dr. Kumar. It has been a pleasure.
So thank you. Thank you.
Good morning. We are at Cardiology Alumni Reunion, and it's there are so many of our alumni who have come, and I have the privilege of having Dr. Sharath and Dr. Sudhakar here. And a fun fact: I was their MD resident when they were doing a DM residency here,
and they were a really cool team to work with. And yes, and great. So. So let's start with Dr. Sharath. Dr. Sharath, can you tell us when you joined and what was life like when you were doing residency in Vellore?
So I joined in 2014. I finished my DM here only and worked for almost 4 years. So my journey was almost 7 years in CMC Vellore. But I have no regrets working here because it is one of the best institute, and whatever quality work I have been taught is has been very useful in my life. And life, if you ask, you can't ask life during DM because the life is you don't have enough sleep. And specific to CMC, just for a humor, we were actually fighting ourselves for beds during DM first year. So after that second year went through, third year we were like refined. Finally, we were entering the consultancy with a good motto, and whatever we have been taught, it's good.
Welcome, Dr. Kilol also. So Dr. Kilol, can you tell us your time in Vellore? What are the memorable moments you had?
I'm Dr. Kilol Kaneria, and I joined the CMC for DM Cardiology in 2014. And I stayed for here around 4 years. So 3 years of DM Cardiology and 1 year of as a assistant professor. CMC not only teaches regarding cardiology, but I learned a lot of things regarding ethics also, which helped me to improve my practice in current scenario. So I consider CMC as my second home, and what the things CMC delivered to me in my life in form of cardiology and ethics, I never believe it will be delivered by any other institute. And whenever I am in trouble, I will remember the CMC, and I will sometime contact my teachers also, and most of the time my problem will be sorted out. So I am very grateful to the CMC and all the teachers and all the staff, and I will consider this as my second home for my lifetime. Thank you.
Thank you for those wonderful words. Dr. Sudhakar, can you tell us something about your teachers and your time in Vellore?
Hi everyone, I'm Dr. Sudhakar. I joined CMC in 2014 as a DM candidate, and initial days it was very difficult, at least for 6 months, to get adjusted to the new working environment and working pattern. So it was really tough to begin with, but as we continued our journey, it was really fun. Looking back, it was we had a very memorable 3 years as a residency, and I worked after that for nearly 1 year as assistant professor. And one of the great place to work and great people to work with. And most of our journey was in old campus, city campus, and we were really surprised and happy to see the our CMC has grown and shifted to a very big and beautiful campus. Very happy to see that. Coming to my teachers, we had a privilege to learn under most senior and very experienced teachers like Dr. George Joseph and Dr. Paul George and Dr. Omen George, Dr. Vijay Samuel, uh, Dr. Jacob Joser, and to name a few, and Dr. John Roshan also, EP, and Dr. David Chase. So, and still we look up to them when we face some issues as far as patient management is concerned, and we're happy to back in CMC after nearly 10 years, and very privileged and happy to see our own teachers and staff. Thank you.
Thank you so much to all three of you. I hope you have a wonderful day. Thank you. Morning. Today I'm with Dr. Pradeep. He's a first year resident in CMC Vellore, Cardiology Department. So, Pradeep, how are you feeling today looking at all the alumnus here?
Hello, good morning, everyone. Actually, I feel much grateful to be studying in CMC because, looking at all the pass outs who has done so much in their respective fields, it gives us motivation and a push towards to become even better. So,
that's there. Yes, sir.
So Pradeep, you come for the first time to study your DM course, isn't it? So the first time in Christian Medical College. So what were your experiences when you joined CMC?
Uh, Actually, I thought like a DM after completing MD, which was hard for us. DM will be a cakewalk. But coming to CMC, our our like whatever we expected, it was completely wrong. There is even lot to learn from DM courses. That's what. So so this journey is like we keep on going, and CMC will aid us in becoming a better doctors.
So looking at all the alumnus who are coming and your our teachers, so what do you feel? How do you think they have impacted you?
They are great people, sir. They have done so much in their fields, and they worked up so much. So it it gives us motivation on one side. On the other side, it puts us on some expectations as well. So so we have to work towards it.
So thank you so much, Pradeep. We are looking to hear from many more people in this alumni reunion. I hope you have a great time. Pradeep, I hope you have a great time. Nice meeting you.